Going on, podcasting world? Welcome back to another episode of the Core Consult RX podcast. Cole and I have a special guest today.
Yes.
We are joined by Dr. Alex Poppen. You may be familiar with his work. He's the author of High Powered Medicine, which is a fantastic book that works through several very important landmark trials that, whenever you hear Cole and I talking about certain trials, we're naming them and we're referencing Alex's book a lot of times.
Yeah, we've never cited it. We probably should while we're on the podcast.
Yeah, so we've used his book several times, and it is fantastic. So he's the author of that, and we'll get to hear some about that as well. He's also one of the content creators and drug information specialist working with Pearls, our longtime sponsor. And Alex, man, it's really good to have you here.
Thank you for having me. No, it's been a listener for a long time, and it's really exciting to join you here today. So thank you.
No, man, thank you for taking the time. So Alex, man, you finished pharmacy school, and you have licenses in like the most different states, I think. No, because I was looking on there. It looks like Missouri, Hawaii, and Texas. Is that correct?
Yeah. They ran me out of 2 states, and I'm in Texas currently.
Ha.
Just kidding. No, I graduated from UMKC in 2018, so got licensed in Missouri, and pretty much immediately after graduation, I moved out to Hawaii and began working as a pharmacist at a community pharmacy chain out there, Belongs Drugs, and eventually I found my way back to Missouri, and then about a year and a half ago, we moved down here to Dallas. So that's what brought me here, and at that same time is when I was able to start working for Pearls full time. So I've gotten to travel around the world a little bit, or at least around the United States, and it's been a lot of fun, and I've got to meet a lot of people along the way.
That's awesome. So how did Hawaii come about? Was that just like something you always wanted to do, or that?
No. So I met my wife at school at UMKC. She was not in pharmacy, which is probably healthy for me. But we met, and she was going into marine biology, and she was going to be working with dolphins. So she actually graduated 2 years before me and got a job working as a dolphin trainer and marine mammal researcher in Hawaii. And she told me I had to get out of Missouri when I graduated. So that's kind of how I was known by a lot of my professors and friends, is that I was dating the dolphin trainer at the time. So
Interesting.
She has such a cooler job than you, man. That's that's probably why people remembered it, because it's definitely for the fun job, and I had the stay inside away from the sun and ocean job. Is there not a lot of dolphins in Missouri?
There's the rare river dolphin, but you're not supposed to pet them.
That's true. That's a good tip.
That could be a problem.
No, that's cool, man. So that's what you guys were going out there so she could do her research and stuff, and you were working out there?
Yep.
How was it, like, being out there in Hawaii for a while? Was it cool?
Oh, it was so much fun. So much fun. It's definitely tough to do for a long time, just because if you wanted to be closer to family, and all of our families in the Midwest. But we had a great time, and just being able to go to the beach whenever you want to, pretty much. And, that's pretty much it. Yeah.
Yeah, that's awesome.
Go to work, go to the beach.
Good life. Yeah.
Oh, that's cool.
And just a lot of great community out there in terms of, working in the area. So I was very lucky with that.
I feel like we had a lot of classmates, or at least a few classmates, who did a rotation in Hawaii. I wonder if it was with Longs, or if it seems like it was like a destination rotation. I don't actually know who they went to rotate with, but
I think Walgreens even has a rotation out there. Okay. I don't know for sure if that's the only one, but yeah.
Yeah. Funny enough, during my 4th year, I did a rotation at a Walgreens on Oahu. So that was my excuse to get to visit Kelsey for at least a little bit while I was finishing up. So
that's cool, man. Well, and then so from there, then you started working for Pearls, and with the book, being written as well during that, I guess in between that time period. Have you always enjoyed like creating content and sort of like educating people?
I don't know if it was something that's been a like lifelong goal, but it's something I fell into a little bit towards my last rotation. It was at the Drug Information Center on campus, and I just found myself kind of really appreciating all the extra, I guess, the deeper understanding that came with actually reading the clinical trial and understanding like either the magnitude of benefit or the lack of benefit for some of the ones that like a drug rep will come in and they'll have like the big blazer and they'll be like, oh, this thing's the best. It's like 90% relative risk reduction, and like, well, what does that actually mean? And so getting to and learning from people who are pros at it at the DI Center. So I started kind of basically building a collection of journal, more or less journal clubs, and over time I was like, yeah, no, this would be a kind of a handy reference, and so I would kind of moonlight as doing that in between shifts at CVS / Long's, and eventually it kind of got to the point where I was like, all right, I'll give this publishing thing a try. So we'll and that's kind of what led me to my job at Pearls, to be honest. So.
Yeah, that's cool, man. The drug info is always something that was like intimidating to me because I love education. I love the concept of drug info, but I'm so the opposite of like the A-type personality.
It's just the mesh terms that get you. You just don't like anybody mentioning mesh terms when it comes to like searching for stuff in PubMed.
I'm yet to have someone explain to me why I can't Google something. No, but I definitely have a lot of respect for drug info, but I don't think I couldn't do it the traditional sense anyway.
It seems like understanding a trial given to me is one thing, and then being able to have a question posed to you and then have to find relevant information is what we don't know as much how to do, and I guess what drug information folks do a little more of, and that's where mesh terms come in.
That's where mesh terms come in. I still use Google.
Yeah, Professor Google.
Professor Google. They don't call him a scholar for nothing. but so was your school like when you were in pharmacy school, was it really heavy on evidence-based medicine, and did they focus a lot on using literature to back up your recommendations, and was that kind of an emphasis?
Yeah. For a lot of it, one of the professors for our drug info class actually more or less wrote a well-known book about it, and he's one of the co-authors, or several of them at the Drug Info are co-authors in the Drug Information, the really big textbook that you can find on Access Pharmacy. So they really at least taught us the fundamentals of just basically how to clear the smoke of or the clinical trials at least, and a lot of our professors really kind of hammered us on if you're going to make a recommendation, you should either support it with the guideline or like a specific trial as to why you think it's good enough to pose to a patient or a provider. So yeah, they really made us at least try to understand our recommendations or the reasons behind the recommendations, rather than just kind of parroting it back to them, which is kind of like the reflex for a lot of stuff.
Mm-hmm. Sure. I remember we have a professor that's very big on evidence-based medicine, and making sure your recommendations are backed up with trials and stuff like that. And I remember I was so proud of myself because I had the name of a trial that vaguely fit the recommendation I was trying to say. And I remember him just looking at me like, "Does your patient, would he be accepted in that trial?" And I was like, "Oh." Huh? Oh no! And it was like,
ask me a follow-up question.
Yeah, I didn't expect a follow-up, but no, it's definitely a big steep learning curve, especially if you haven't spent a lot of time, actually looking and utilizing trials in a way.
I remember anytime a professor would include the names of trials in their slides, inevitably somebody would raise their hand and
do we have to know
this for the test? Yeah.
You do now. That's what I tell my PA students.
You do now.
You do now.
That's what you get for asking a question.
Yeah, don't ever ask something ridiculous like that again. No. So when did you have the idea for creating and writing high-powered medicine?
Well, like I said, the initial idea was just kind of a way for me to stay semi-sharp, and I did start to enjoy the actual reading the clinical trials and understanding like, oh wow, these are some of these drugs are incredibly effective and super useful, and some of the ones that you see are like, yeah, that's kind of a miss, but it's eventually I was like, this is a good reference for myself, because I was a co-preceptor when I was in Hawaii, and I would, one of the things was, oh, here's a journal club idea, and I'd give it to him, and then we could actually talk about it a little bit more in depth, because I'd already had a little bit more exposure to a certain trial. And then eventually I kind of was like, oh, I'll get out of my own way and put this out and share it with other people. And I was very hesitant about doing that at first, because I wasn't sure, like, oh, is this going to be good enough? Is anyone going to care? What if they care too much? What if it sucks? And just the whole thing that comes with, trying to, or sharing anything and it to the out in the open. But I've been very, very lucky and very thankful that the people that do find it seem to enjoy it. It's been a nice research for myself, or continued nice research for myself, and I'm very, very thankful.
Well, and as far as like creating the book, itself, like how did it start? Did you just take the summaries and stuff that you had already written for yourself and just sort of start putting them into alphabetical order by trial name, or did you have to go through and like have somebody? Did you have somebody come in and like go through it and like back check you or anything like that? How did you kind of work, like actually put everything together?
So I'm a one-man team when it comes to this. I would basically do the use the template I like to use and go through and comb through the data and write it out and try and make sure I'm not all over the place with my word phrasing and the terms I'm using, and just trying to be a little bit consistent from trial review to trial review. And then I would kind of come back and basically just painstakingly check everything again myself, since it was just kind of a hobby project for a long time, and eventually kind of grew into something a little bit more, still requires a lot of editing every now and then, but and just maintaining it, but just a lot of fact checking and going back. Pretty much any hour spent in is about 4 hours worth of reviewing on the back end, is what it felt like, especially getting it for publishing, and just it's like a root canal.
That's a good way to describe it. It's basically like getting a root canal without any sort of numbing.
It's really motivated
agent.
me to write my own book.
Yeah.
It's like I tell everybody they should definitely do it.
Yeah. Right.
No, what's funny is you mentioned that whole that inner dialogue of whether you should put things out and are people going to say. I mean, Cole and I think we did the same thing. We were, but the first video that we ever recorded before the podcast ever started, or anything, I think Cole was still a student at the time, actually, and we recorded one video. I think it was the Affirm trial, and it literally took us for a 5-minute. And not including the editing and all that crap, it literally took us probably 8 hours to do which looking back, video. It's like, what could we have possibly been doing? We didn't stop for any breaks to play virtual reality or nothing.
No video game breaks, and it still took 8 hours.
That was the best preset.
I remember you had a little chalkboard. I think we were even like outlining it on the chalkboard, and then we had to like type out my lines, and then I had to try to relay them, and it was very bad because it was the first time I'd ever been behind a microphone, and then we redid that multiple times, and then we had to make the slides. Yeah, it was all day.
All day long. It's probably still on YouTube somewhere.
I'm sure it is.
Yeah, that's a very familiar scenario for me. Just as anything I'm doing, it's like I have this big block of unrefined wood or stone, and I have to take like 8 or 9 passes before it gets even close to being something. I'm like, well, now I can finally do it for real this time. So
anytime we put anything in writing, I feel like we do kind of overthink it big time. The nice thing about our current medium is that we just talk. Say stuff. So sometimes we mess up, and that's okay. It's a little harder to fact check when it's not. I mean, I guess
it's really not.
There's probably a transcription.
It makes us feel a lot better, though.
It makes us feel better, yeah. More comfortable when we mess up.
As long as we don't read the Reddit, then we're good.
Right.
Oh.
Yeah. So the book itself is in the 3rd edition, or about to be in its 3rd edition?
Well, it's the second edition is currently out and live. It started off with just over 100 trials when it was first published in 2021, and in December of 2022, I got to 151 or 2 trials, and slowly but surely working my way towards 200. And I think that'll probably be the third edition whenever that comes out. Just trying to make them either semi-relevant trials or useful stuff, because there's a whole bunch of just kind of crazy off-the-wall trials. I could probably fluff it in there, but in the topic of like kind of chronic disease management, it's more on the outpatient side anyway. You start to kind of scrape the bottom of the barrel, and I mean there's still tons, I'm sure, but in terms of like relevant to current practice,
yeah.
So
How do you go about kind of figuring out which trials you are going to include? Do you have do you ask for suggestions and things?
Every now and then I'll get a suggestion, and in general, the most useful way or the most helpful way for me was just going through the reference section of the clinical guidelines themselves. So whether it's the hypertension, cholesterol, diabetes, they have, especially heart failure, like that one has like gobs and gobs of landmark trials referenced. I would just kind of go to the back, and like out of like the 800 or references that they have, I'd just kind of start scanning for any kind of fun looking name, and I would just have like a running list of things, and I'd just kind of go through them, and some of them would be not very relevant, and some of them I'd be like, oh yeah, I do remember hearing about that one from school, or that one's actually will help answer a question that I've had for a while for myself, like the precision trial. Like, is that going to be any different, Celebrex versus general NSAIDs?
We just talked about that last episode.
We did, and you actually mentioned what probably my most important question is, which is if it doesn't have a cool name.
I was literally about to ask the exact same.
Like what do you do with your header? Or do you just, if it doesn't have a cool name, it does not get included?
I think there's only been maybe even like 1 or 2 trials that didn't have like a very fun name, and I would just find like somewhere like it's called the HPTN 083 group trial, and that's just what it got indexed under on clinicaltrials.gov, or I think the other one was just the diuretic comparison group, the one where they were talking about the VA study with the when they looked at chlorthalidone versus HCTZ, and didn't have necessarily a fun name, but it's.
You found some way to designate it.
I found something. If they ever name a trial that's just a boring name, then I'll have to message the authors and see if they can.
It's not worth it.
Yeah, because I feel like there's definitely some trials you run into where it's like they're important, but there's not a name associated with it, so it's like okay.
And the one we're going to talk about today, it's pretty on the nose.
Yeah,
pretty on the nose. Actually, I'm not sure that. I can't really think of too many trials that have the brand name of the medication as what the trial's called.
Is that the brand name of the medication?
Isn't it?
I don't know.
It is,
yeah.
And I thought that was hilarious that they went with that.
I know. I mean, can you think of any other, which there was an original Ledoco trial in 2013 or something like that. Or an older one, I guess, and this was like Ledoco 2, I thought.
This was the sequel to, I think, the Colcott trial.
Yeah.
Where it didn't show as great of a benefit, so they all right, we'll give it some time, we're going to try again. And yeah, they picked, I don't know if they picked the trial name first or the trade name first, but Ledoco is a kind of a goofy name for a drug.
It is, and I'm amazed that say it was the trial name first, I'm amazed that they were able to get the brand name approved, because I think that there are rules about if it can be kind of an advertisable brand name in some way. I don't know all the rules, but I thought I heard something about that.
I don't know all the rules.
I swear it's been brought up. Sometimes brand names
I don't even know one of the rules.
They will get denied for reasons. You have to be. They're obviously very strategic about that, how they choose them, but they can be denied.
I think they made Brintelix changed its name to away from Brintel, because it was too close to Brintella and
Brilinta.
Brilinta, thank you. But yeah,
I remember that. Brintelix is what it used to be called. Now it's Trintelix.
Yeah, and I guess that might have been like a med safety thing, I suppose, or maybe it was a marketing thing. I don't know.
I remember.
I think it was too many fatal bleeds.
Yeah. Oh, jeez. Yeah, I remember like vividly this. It was an emergency room physician that came into the pharmacy when I was still working for like Walgreens, and it was right after that switch had been made. He had been on Brintilix, and he was like, "What is that?" And like I said, "Oh, it's the." I just gave him a 2-second summary of why. He's like, "That's got to be the stupidest thing I've ever heard." And he just got so. I'm like, "Yo, I didn't choose it. I don't know why you're mad at me. I didn't do it." It was. I don't know why that just popped in my head. I haven't thought about that guy in 10 years.
He probably thinks about you all the time.
He probably does.
Stupid pharmacy student. Why did he tell me about that brand name change?
He's so angry. But so we'll definitely go through that trial too. But as far as the future for high-powered medicine, what do you like to see this going? Like, would you want this to be a full-time gig at some point, or do you like having it kind of just be a side hustle or whatever you want to call it?
Yeah, it's been a nice little hobby project, and I don't know if it's ever going to be ready to be a full-time job for me in terms of keeping the lights on. But the big success was it kind of led to my current job at Pearls, which is good enough for right now for me. So I'm happy to see it kind of just plug along a little bit, and if it gets more and more popular, or if it gets into the hands of other people and they can find it useful, that's great too. But if not, it's a great way for me just to kind of keep chugging along and do what I like. So,
and plus, when you have a spouse who's a dolphin trainer, I mean, surely money is no object. So I'm sure that's not a concern.
We're swimming in it.
Right. There you go.
No pun intended.
Yeah.
That's awesome.
So,
you might have to switch careers, man. I'm going to try the marine biology thing out a little bit. That sounds. I'm not going to lie. I'm thinking about it. It sounds way more fun than doing this.
Yeah. In terms of fun jobs, it definitely has me beat by, not even close.
Have you gotten to like swim with dolphins as a assistant or anything?
No, but she gets me in. She was able to get me in when we lived out there, and when we moved back to St. Louis, she helped open the aquarium at the Union Station. And now she kind of pivoted, and now she does voice acting. So she's she's bouncing all over, doing all the fun jobs. And
she's way more interesting than all of us.
Than all of us put together.
And you went from a community gig to drug information, which is probably considered a little more of a slower, not busy.
Yeah,
but
we like it, but
maybe a less interesting career option to some
from
people.
a population standpoint.
Right.
I got more boring, and she just keeps getting more interesting.
People are like, "What do you guys do for fun outside of pharmacy and outside of work?" I'm like, more pharmacy stuff.
Yeah, right.
So we get that for sure. So. It's all good. To each his own. We have fun, but voice acting that's a good idea.
I know.
God, could you imagine how bad we'd be at that?
We would be so.
We can barely do this. It's not even
bad
acting.
at that.
You guys already have the equipment for it. You guys are halfway there.
We do. We're just don't have talent piece.
Yeah, the laryngeal equipment. Right. Because we already get made fun of our voices on a podcast where it does not matter nearly as much.
Could you imagine if we were trying sound a certain way?
I've done some accents on here before.
That's true.
Have I not?
I'm sure they've hit.
We probably cut those out.
Yeah, that's the only time I've ever edited. So, Alex, man, let's go through this Lodoco 2 trial, and will you kind of take us through and just give us an idea of how the book works, how people could use it if they were getting a copy of it?
Sure. Yeah. So the book works. It does everything's either indexed at the back by disease state or drug. If you're using it's alphabetical otherwise. If you're using the online database, it's all just kind of there, and you can filter by disease state or just Control F for whatever trial name or drug name you're looking for. But just going into I don't even know if it's sharing my screen. If not, it's fine. But yeah, the Lodoco 2 trial, that one was published in 2020. And the objective of it was to determine the safety and efficacy of low-dose colchicine for the prevention of cardiovascular events in patients with chronic coronary disease. And this one was kind of an interesting trial that caught my eye initially, just because you don't think of colchicine as being good for anything other than gout attacks historically. So it was definitely didn't know what I was going to find when I read it the first time, but the primary endpoint they were looking at was a composite of cardiovascular death, myocardial infarction, ischemic stroke, or ischemia-driven coronary revascularization. And overall, the general patient population were those who had established coronary artery disease. Most of them, roughly 84% had a prior acute coronary event or revascularization. Most of them were on guideline-recommended therapy, statins, ACE or an ARB, beta blocker, and antiplatelet therapy. Looking at what they actually were testing out method-wise, they just were giving people colchicine 0.5 milligrams once daily versus matching placebo. And I thought that was kind of funny compared to, colchicine is available or Colchris is 0.6, which made me kind of think if this it does do well, how many people are just going to be put on the 0.6
Sure.
Off-label,
Sure.
we'll say. That would be not the FDA what they want, but anyway.
Not with the drug company who got it approved once either. I'm sure.
Yeah.
Right. Yeah,
surely that's why they went with 0.5.
Well, wasn't the 0.5 the one the strength that was available like in Europe and stuff? Or am I making that up?
Well, that's a good point actually, because I think this was. Did you mention something about?
It was in
it's like
Australia and the
something else?
Netherlands. I think the study was done in.
Well, that's a high possibility. That's a possibility.
That's a good question. Yeah, it's Netherlands. I think this was all over the place, but
They probably do have a different dose. I should point out that I now understand Lodoco, low dose colchicine.
Yeah.
Didn't get that at first. So
it's
actually a reasonable brand name now.
Yeah. Oh, I was wondering why you were so confused. I thought you were just
didn't get it all.
Yeah. Low dose.
I got it.
Yeah, we learned so much in real time.
There's at
on this
least 2
podcast.
people listening who just got it as well. So you're welcome. I'm speaking for those 2 people.
If that's true, please send us a message so that Cole can prove us himself right. But I have my doubts. Sorry, go ahead, Alex.
No.
This is why people stop listening to us.
This is why I listen. So they overall the trial lasted about 29 months and had about 5,500 patients that underwent randomization. Overall, there was about the primary composite outcome occurred in 6.7% in the colchicine group compared to 9.5% in the placebo group. So this was a statistically significant difference. Absolute risk reduction of about 2.7% and a number needed to treat of about 36, which looks good. And overall, like looking at the individual components, it was consistent morbidity benefit in terms of showing a significant reduction for revascularization, myocardial infarction, and stroke. But when they looked at actual mortality for the cardiovascular death component, didn't quite achieve a statistically significant difference. So it was numerically lower with colchicine, but not to a statistically significant magnitude. So kind of more of a morbidity versus mortality, at least based on the results of this trial.
So was it being driven mostly by MI and ischemia-driven coronary revascularization?
Yeah.
Okay.
Yeah. So the cardiovascular death, it was 20 events in the colchicine group and 25 in the placebo. So better, but not enough to really say that it's a significant reduction.
Gotcha.
So a lot of these patients were secondary prevention.
Yeah, most of them. I think, like I said, it was about 85% had a prior ACS or some form of revascularization, and all of them had evidence of coronary disease when they looked at them on angiography or tomography.
And they were all on, or for the most part, all on lipid-lowering therapies. A lot of them on ACEs and ARBs and beta blockers, that sort of thing still.
Yeah, and that's a great point to kind of highlight because the results need to be interpreted as colchicine in addition to, in general, like evidence-based therapies or recommended baseline, lipid, blood pressure, and general ACE or chronic coronary disease medications.
Gotcha.
I thought it was interesting too that it looks like 95% of the patients in the study had stage 1 or 2 CKD. Does it look like 5% had stage 3A? So I guess everyone had some form of CKD. Am I right about that, or am I making that up?
And it's and colchicine has it's contraindicated in severe CKD, right? Like less than 15.
I think it's like you have to do like I'd have to double check myself, but I want to say it's like maybe a half of a tablet like every few days or something like that.
Gotcha.
I don't know. I can't remember off the top of my head.
Yeah, no, yeah, there's yes, stage 1 or 2. Most of patients did fall in that category, which I have to refresh my memory on the staging, but that could be anywhere from like 60 to 90.
Yeah, or greater than 90 even.
Greater than 90. Yeah.
One of the exclusion criteria was EGFR less than 50.
Okay, so they had to have a
I guess that's where the 3A comes from then.
Yeah.
Because they only had 5% that were in that 3A group, which I guess is technically down to 45. But that's interesting. I guess that's probably what they were trying to avoid is any kind of issues with the kidneys.
I should say that there is a 0.5 milligram tablet of colchicine available in Australia, branded as Colgout.
Colgout.
And there in other countries there is as well. Even Canada
that's a cool name.
Canada has an extended release version of 0.5 milligram colchicine called Myinfla. So yeah, that's probably why they chose that.
That's cool.
Yeah.
Kind of wreak havoc to all the U.S.-based farmers.
I know, yeah. But you're right. I imagine there will be a lot of 0.6s floating around first for cost reasons.
What about adverse effects in this case?
For the most part, the kind of one that kind of pops out as initially concerning is the potential for rhabdomyolysis, because that's kind of one of the... You see, I have statin plus colchicine, and that was a drug alert that we would pop up all the time at the pharmacy because they interact that way and can increase muscle aches and pains, and in rare cases, rhabdo. But they only had one case noted over the full course of the trial, and they did achieve full recovery, which good. So overall, it doesn't seem to be a very notable adverse effect or a common one to worry about in terms of adherence. But that was the main one that stuck out. They didn't seem to have a whole lot of GI complaints that you would see with higher doses of colchicine. And
I think it's funny that numerically there was less instances of gout. They reported that.
Yeah. Thanks for including that.
That's a nice thing to highlight.
Yeah,
I think
the gout medicine worked.
Yeah. Jinx. I think the rhabdo piece is a very good point, because 94% of these patients were on statins. So I'm sure there's going to be a lot more, like you said, of that interaction popping up in the pharmacy, and likely a fair amount of pharmacists pausing and calling for clarification or something to confirm. Like if it pops up, I can't remember exactly how it pops up, but I'm pretty sure it's a nice big red warning that it pops up with. And so this would make me feel comfortable that it wouldn't be something that would need more than a counseling about signs and symptoms of rhabdo or something like that.
Yes.
My thing, did they report on like GI issues at all?
That thing, they had a hospitalization for gastrointestinal reasons in table 2 of the actual trial, and it was 53 versus 50 comparing the colchicine and placebo group. So not any significant difference between that, with like the concern with colchicine at higher doses, and that being why you kind of stop after 1.8 milligrams daily for most gout attacks or flares. Would be like you just kind of have some intolerable stomach issues after that point, and not any added benefit.
Interesting.
That study is included in your book as well, right? The colchicine high dose. I thought I saw it. The high dose colchicine versus lower. Maybe not.
I do.
Well, there's one for version 3.
Yeah,
yeah. I'm gonna document that right now.
It's amazing that almost 100% of the patients were also on an antiplatelet as well. So another thing to note about if your patient fits into the window of this trial is or not antiplatelet, but 67% on single antiplatelet, 23% on dual antiplatelet, and 12% on anticoagulation. So almost 100% on an antiplatelet or anticoagulation.
Yeah. So and kind of like how I view Ledoco or this lower dose of colchicine fitting in whenever it does kind of come to market would be, this is kind of an add-on after you've almost kind of, I don't want to say perfected their current pharmacotherapy regimen, but like you should not be trying to use this in place of anything or as a single agent regimen. This needs to be like maybe one of the final things that you consider adding on, and like a high risk person who's already had an event and still remains at an elevated risk.
Yeah. But it's nice. Gives us another option to decrease risk. And even on top of all that stuff, a number needed to treat of 36 for the composite, I think is very solid. I think it's pretty solid.
Yeah. The Agree trial, that's the one I was thinking of.
Agree.
And I don't know why.
We'll agree to disagree.
I saw Aim High. I saw Aim High in your book, and I don't know why my brain was like, "Oh, that's the one." I was thinking, I'm not even close. And also, that sounds like you want the higher dose, which is wrong. So I'm an idiot. But yeah. I'm wondering if colchicine and if I mean, obviously the data is not like extremely, impressive, I guess I would say, but like I'm wondering if with all the talk around aspirin, I'm wondering if it's going to be kind of like I know it's totally different as far as mechanism, but I'm almost wondering if that's going to be sort of like a replacing, or at least for some patients maybe they have a higher bleed risk or something, maybe an alternative.
Secondary prevention.
Yeah, possibly.
I mean, almost all these patients were on some sort of antiplatelet or anticoagulation. So.
Dual I guess it wouldn't be antiplatelet anymore, but dual therapy with colchicine and clopidogrel or something.
Yeah, Plavix and colchicine. That'd be interesting. Yeah.
We just came up with something, I think.
Just another. Like there's going to be all these quad single pills where it's going to be statin, beta blocker, colchicine.
Colchicine. Who'd have thought?
Yeah, rhabdomyolysis in a pill. Not really.
Yeah, that's and tell us, because you have the hard copy book, and then you also have the database where someone can go, like if they had to, look up a trial real quick, they could just go on the database online and search it and see it digitally right then and there. If someone wants to purchase the book or access to the database, where do they go? What do they do?
Yeah. So if you're interested at all, you can start off by just going to highpoweredmedicine.com, and you can create a free account, and you can download a copy of 10 free trials just to kind of keep as a PDF and get a free sample of what the book looks like and what you'd be getting if you did purchase the full copy. You can buy a PDF from the website, or you can buy a hard copy from Amazon and have it shipped to you overnight with Prime, and or if you prefer to have something just instant access anywhere there's internet, you can buy an annual subscription to the database. And the upside of that one is that you get instant access to any trials that get added as I'm adding them or putting in. So anything that's new, I'll drop it in, and you'll have instant access. Versus the book, you'd have to wait until the third one gets released, that might be a while. So, it's $19.99 for pretty much all of it. If you want a hard copy or hardcover, that's a little bit more, but try to keep this pretty low hanging fruit in terms of price, and make it easy for everyone to enjoy.
Yeah, no, and for those of you who are watching the video version, the hard copy is very, very nice too. I'm actually when I got this, I was like, man, this thing is legit. This is a really well made book and stuff too. So I like it. It's definitely worth it to get the hard copy for those of you who want the physical version. But I like the database as well, especially since you said as you add more things, and then you can kind of just see all the new content as it comes out. That's pretty cool.
It's very cool. Yeah, this is great. This is a great idea. It sounds like something that I would think like, oh, that would be really cool to do. And then maybe I would sit down and put together like reviews of 2 trials, and then I would completely stop there and move on to something different. Like I do not have the mental fortitude to actually do this. So yeah, kudos for doing this on your own. I mean, it must be thousands of hours.
Very impressive
of work. So
it's a very humble beginnings and over a long period of time. So anybody who's, I'm sure you guys know what that's like, starting off and then seeing where it goes. So, happy to see how it's grown over time.
What's been the time frame as far as from like when you finally said, okay, I'm going to create a book to now? How long has it been? Do you know roughly?
Yeah, so I guess the seed of the idea started like in my last rotation before I graduated in April of 2018, and then it eventually got over time as I'm adding it and kind of getting it ready. I published it in 2021, the first edition, and that was kind of funny because I did it when I was on COVID leave. I was working with Warp Speed, and I brought home COVID to me and my wife, and we had 2 weeks off, and I
Nice.
used that to finally buckle down and do all the last editing stuff, and then then eventually about a year and a half later, I put out the second edition, and just finding time for it here and there, in between life and normal other work, and just keep plugging away.
That's awesome, man. Yeah, good for you. That's a huge undertaking.
I've got a good advertising idea for you. What you need to do is, if somebody buys like the nice hardcover copy, then your wife will record one of the trials in like a certain voice. Let's go with Minnie Mouse or something like that, and that way you can pair her,
do the audio version.
Pair her voice acting along with
audiobook.
Yes, with the yes.
That's
audiobook.
Cole, that might be one of your best ideas.
Tell you what, I'll be expecting royalties.
Yeah.
Yeah, it's better. It's definitely a better idea than me doing it. Because I can barely record 2 or 3 sentences without tripping over myself. So
it's okay. We can't either, and we do this all the time.
Somehow we've done it for 200-something episodes. So here we are.
Yeah, just as long as you don't listen to the episodes back, you can't tell how bad you do.
Right.
That's right. You just got to barrel forward.
That's the
when
key.
There's no quality control, you don't actually have to worry about that kind of thing.
Yeah, that's true. We fired the quality control guy.
It was Creed.
Yeah. So if people want to contact you or follow you on Instagram or anything like that, where can people find you at?
Yeah, so the Instagram's probably the place I'm most active, just High Powered Medicine. I have a Twitter under the same, or High Powered Med, and if you want to reach out to me personally, you can find me on LinkedIn, Alex Poppen. There's also just the actual High Powered Medicine page, but most of the activity I do in terms of sharing stuff and putting things out is on the more social need on Instagram and Twitter. So that's where you can find me if you want to see what else I have going on, or just want to look at the other, see what I've been putting out on those feeds. Feel free to take a look.
Sounds good. Well, make sure you follow him on Instagram and LinkedIn and all that good stuff. And I will link in the show notes it's how to get the book off Amazon or purchase the digital copy or the database subscription. I'll put all that in the show notes so you can find it. And Alex and I are going to be working together, kind of cross promoting the podcast and the book and stuff. And so, I want to say, with you here, I really appreciate you agreeing to work with us and stuff going forward. And I'm excited about this. Like we're very particular about who we because Cole and I are very bad salespeople unless we actually believe in something. So we've gotten offers. We've gotten offers from these. Oh, if you drink this, it'll cure your ADD and all this stuff. And I'm like, I just can't do it.
No.
I just don't believe in it. And so you and Pearls obviously is another big one. But we both think the book's awesome, and so it's going to be. It's been really cool having you on the show, and hopefully we can get the word out and get some people over there to take advantage of this opportunity, because it's all these landmark trials right at your fingertips. What are you doing? But,
it's I was just laughing because I'm a terrible salesman myself, and I'm it's good. It's really great to connect and meet and work with people who are also fans of EBM and all the fun stuff that comes with just enjoying talking about pharmacy. So
the cool kids.
I knew I'd make it.
I told you, Mom.
Just let the dolphin trainers train their dolphins.
Yeah, we'll be talking about.
We'll
studies.
Sit around a table late at night and talk about evidence
with our cigars and bifocals.
Right.
Until we get COPD.
Yeah.
But all right, man. Well, we appreciate you coming on the show. We won't keep you, and we want to be respectful of your time. But thank you so much for taking the time to come on and do this with us. And everybody listening, make sure you check out the book, and whether it's hard copy or subscribing to the database, definitely encourage you to do that. And also, while you're at it, check out Pearls. So that'll also be in the show notes, pearls.com/coreconsultrx. And a lot of great content coming out of there as well. And Alex is producing a lot of that stuff as well. So you can get the book and you get him on Pearls. He's everywhere.
Right.
So thank you guys so much for listening. And let us know if you have any questions for Cole and myself. Obviously, you know how we can get in touch with us. All that will be in the show notes as well. Until then, we'll see you guys in the next episode. Have a good one.